Good evening and welcome. And I think that I have an audience out there. It's sometimes hard to tell when we're on these webinars and all we see are ourselves. But thank you everyone for joining us this evening. We are so pleased to be able to bring this webinar to you from Kidney Cancer Canada. And it's going to be highlights from GU ASCO 2023. And I'm sure there'll be some good information on clinical trials and what's new in the landscape for kidney cancer and what might be coming forward. We have two excellent doctors from the Ottawa Hospital joining us this evening. And I'm going to do a brief introduction for each of them. And then I'm going to pass it to Dr. Rodney Breaux, who is joining us. And he is a urologic oncologist. And then we will pass it to Dr. Neil Riome, who is an oncology specialist. And then at the end, we'll have some questions and answers. So please, as they're talking, if you would just want to make note of something that you might want to bring forward later. When we do have the questions, when I come back on, I will ask that they're not of a personal nature, that we'll save those for your doctors, but any other questions that we might be able to help you with or what might be in the landscape, we're happy to help. I just wanted to briefly say that we're a patient organization and we're patients and caregivers. We're happy to help in any way we can. So please reach out to us if you have questions or need some guidance or maybe need a little help with finding an appointment. And we're at www.kidneycancercanada.ca. And you can always email us at info@kidneycancercanada.ca. So I'm going to, sorry about the telephone, but I'm going to do a brief introduction for Dr. Rodney Breaux. And he is a urological oncologist, Division of Urology at the Ottawa Hospital. And he is a scientist with the Ottawa Hospital Research Institute. Dr. Breaux also holds a master's in clinical and translational research, and he specializes in all aspects of urological oncology, including open, laparoscopic, endoscopic, and robotic surgery. He holds the Department of Surgery Chair in Urologic Oncology Research, and he's a Canadians and Cincinnati Bengals fan. We were chatting about football. I'm a Kansas City Chiefs fan, so we had a bit of a laugh about that. I'd also like to introduce Dr. Neil Riome, and Dr. Riome graduated from Queen's University with his medical degree and got his medical degree at University of Ottawa, internal medicine at Dalhousie. Thank you, Neil, for joining me for a second. And back to Ottawa for his medical oncology in lung and GU and a Master's of Science in Clinical Epidemiology. An associate professor at University of Ottawa and now the head of the Division of Medical Oncology at the Ottawa Hospital Cancer Centre. A member of the National Cancer Institute of Canada's Working Group on Economic Analysis. So he's not only got the medicine, he's got the numbers too, and chair of at the Royal College of Physicians of Surgeons Medical Oncology Subspecialty Committee. So welcome, gentlemen. I'm so glad you could join us this evening, and we're ready to be enlightened, and we'll let you take it away, Dr. Breaux. Thank you so much.
Thanks, Christine. It's a pleasure to be with you guys today. Some of you I know, some of you I don't, but Christine reached out to me after I presented this to the Canadian Urology Association group. And so all these slides are what I thought were kind of interesting from this conference. This is a conference of surgeons like me and medical oncologists like Neil and other patients, researchers. And there are certain papers that tend to stand out. And so I think Neil and I picked some of these research studies that we thought were interesting to us, and hopefully they're interesting to you as well. Like I said, these slides were originally made mainly for physicians. So if there's some jargon that I use, I'll try not to, but if there is, please ask for clarification, and I apologize. The three areas that I thought were quite interesting from this conference, one of them related to adjuvant therapy, and there are a few papers that I'll present that I think certainly were interesting to me and hopefully to you as well. I'll be speaking to the Light Spark study and the Zircon study, and I'll explain what those are when we get to them. So as many of you, I am sure, know, this has really been a kind of a major topic lately, which relates to adjuvant treatment. And what adjuvant treatment means is if somebody has a kidney tumor and the kidney tumor is removed, and there's no evidence of cancer elsewhere in the body, which is what we hope, and we always hope that when that happens, the person's cured. But we also know that if the tumor was a very aggressive variety, there is a chance that that cancer might come back. And so for many years now, we've looked at trying to give treatment even before the cancer comes back somewhere in the body to try and prevent it. The hope is that if you treat things very early, you treat it before it's picked up on x-rays, that you'll have a better chance of cure. And we did these types of studies with tyrosine kinase inhibitors like sunitinib and pazopanib. And when immunotherapy drugs came around a number of years ago, very shortly after some of these clinical trials were done, looking at what if we give immunotherapy to patients who are really high risk of recurrence, and could we potentially give this treatment for 6 months or a year and potentially prevent the cancer from coming back. And obviously that is our hope. This got a lot of attention about 1.5 years ago because one of the trials, called the Keynote trial, showed that 1 year of therapy reduced the time to recurrence. This is a summary actually of 4 studies. So this is a meta-analysis and of those 4 studies. So each of these red dots, hopefully you can see my cursor here, but let me see if I can do this. So each of these red dots represent an individual study, and the names of the studies are Checkmate, Emotion, Keynote, and Prosper. This line, this vertical line, which is a black line by the number 1, means that there is no benefit to the treatment. Any dots that are to the left of the line, for example, along this Keynote, that's the study I talked about, shows that there was a benefit, and that's why we were so excited about that. The other trials, the other 3 trials that show no real benefit, unfortunately, were reported after Keynote, and we were a little bit surprised because we were so excited about Keynote that we thought all of these other trials would also show benefit, at least in preventing disease from recurring, while we waited other outcomes. The most important outcome, of course, is not just delaying it from recurring, but never coming back. So helping you live longer, the outcome that we call overall survival. And there are a couple of things about this that I think are important to take away. One is that this, this Keynote study, which is squared off in red, shows that the benefit is about 35%. So about a 35% reduction in time to cancer coming back after surgery. That's pretty good. But if you look at all the trials together, the benefit, if there is even one, is about 15%. And I want you to remember though that number, 15% reduction in the time to recurrence. Now, we don't have an overall survival outcome, which of course is what patients care the most about, and we certainly care the most about, because we don't just want to delay it from coming back. We want that delay to translate into living longer and living better. And also an important part of these trials, and this is 3 trials had reported the sort of side effects of the treatment. And everyone who has taken these medications know that some of the side effects can be quite severe. These are grade 3 side effects or higher. So grade 3 side effects are very significant side effects, but not life-threatening, but could be quite serious, could mean an admission to hospital, could mean having to take steroids for a significant reaction, that type of thing. And what the meta-analysis showed us for those side effects is that people who got that treatment had 2.5 times the side effects of the medication. So some benefit, maybe, but definite side effects. So that is always the trade-off when it comes to any treatment. And this is the overall analysis showing that it's 2.5 or 2.5 times. So, as I mentioned, if somebody has a delay in cancer recurrence, of course, that sounds like a really great thing. But the problem with adjuvant therapy is that many patients will not recur. They'll be cured with their surgery alone, and exposing them to those side effects are worrisome. So adjuvant therapy only really makes sense is if you're able to cure some people early that you would not be able to achieve a cure on later. So that benefit has to, be a benefit that you can't catch up on if the cancer recurs and you get the treatment at that time. So these authors looked at a different study, and they looked at medications, and you're going to see on the next slide, the line in blue are tyrosine kinase inhibitors like pazopanib or sunitinib, and in red is adjuvant IO treatment, so immunotherapy. And what these authors wanted to do is say, well, look, we're waiting for these trials to be reported, but we know that some of these patients, especially in the United States, have gotten these treatments. What happens to those patients from a survival perspective? As I had mentioned years ago, and actually Neil was one of the main authors on at least one of the studies for adjuvant therapy, showing that unfortunately tyrosine kinase inhibitor given after surgery as an extra treatment did not show a benefit. So if immunotherapy benefits patients, we would expect that the red line on the next slide would be better than the blue line for survival or how long they live. Now, I don't know how many people are familiar with looking at these sorts of lines, but this is essentially an estimated survival curve. And on the y-axis, so horizontally here, hopefully you can see my cursor, it goes from 0 to 100. So all patients are alive at the time of starting treatment, obviously, but unfortunately, people do end up passing away over time. And the red line here is the immunotherapy, and the blue line is the tyrosine kinase inhibitors. And as you can see, these lines really, for the most part, overlap. On the x-axis on the bottom, it's in months, so 0, 12, 24, 36, 48 months. And unfortunately, at least in this study, it looks like those patients who had immunotherapy did not live longer in the end than those that got tyrosine kinase inhibitors. So that's a little bit disappointing. What's more important than this type of study is the results of the randomized trials, and we are still awaiting those, although probably for at least 3 of those 4 trials, we're not really expecting there to be an overall survival benefit because the medication didn't even delay cancer recurrence. Now, this I thought was one of, and again, I'm going to reference back to the study that I showed you at the beginning. This was a digital survey of patients. This was presented by Kidney Cancer Cure Group. I believe they are out of the United States. They did a large survey of patients, mainly patients, but also some caregivers and doctors. It was widely advertised on social media, and they had over 1,000 people fill out the survey, which is really great. Now, 74 of those patients actually were receiving adjuvant therapy. So that's quite a large number of patients because we're still very early in the data on that. And what we found was that patients seemed to really overestimate the benefit of adjuvant therapy. Remember, I said in that pooled analysis, there was about a 15% benefit in reducing time to recurrence. These orange lines show what the estimated risk reduction, the green and orange lines here are actually asking patients, what do you think your risk of recurrence is if you had a stage 1 cancer, stage 2 cancer, stage 3 cancer? Now, the green lines are the recurrence risks, the true recurrence risks. It says doctor, but really what it means is based on mathematical models, we know that someone with a stage 1 cancer has about a 13% risk of recurrence. But patients thought that risk was much higher, 28%. If we look at stage 2, again, the real risk of recurrence was 23%, but patients believed the risk was much higher at 37%, and the same for stage 3. In the bottom here, in the red box, is fairly alarming. 25% of patients who are actually receiving adjuvant therapy believed that the adjuvant therapy would reduce their risk by over 50%, which is quite a large reduction. But remember, what the study showed is not 50%, but actually 15%. And even in the best trial, that keynote trial, which may or may not be accurate, the reduction was only 35%. So it seems like, in general, what this tells me is that patients need to be better educated on, first of all, what is their risk of recurrence? And secondly, if they are considering adjuvant therapy, what are the benefits that have been seen in these trials? What are the side effects that have been seen in these trials? And do we really know that patients will live better if they receive adjuvant therapy? And right now, with the limitations of the data, we don't know if patients will live better. In fact, they may even live worse because they have side effects of these treatments. Okay, so switching gears a little bit, belzutifan is a medication that is a new class of medication. The LightSpark trial, an update of the LightSpark trial was presented at this conference. It's a pill. Now, it's a pill, but that doesn't mean that there aren't side effects of this treatment. There are some, but it's a new type of medication that acts on the pathway of the von Hippel-Lindau gene mutation. So some of you may know von Hippel-Lindau disease is a mutation in a gene that often leads to kidney cancer. But anybody who has clear cell kidney cancer may also be interested in this, because even though most patients who have a clear cell renal cell carcinoma do not have that mutation in their whole body, the cancer tumors often will have that mutation. So a medication that works on this VHL pathway likely would have a good benefit to patients who have VHL, but may even in the future potentially benefit patients who don't have VHL but have that mutation in their tumor. So this is a study of only 61 patients with VHL. But the reason that we're so excited about this is represented in this, what we call a waterfall plot. So each of these colored lines in the graph show a reduction in kidney tumor size. On the very far right, we see 4 blue lines. That means that in those 4 patients, their tumors went completely away on this medication. The ones that have green lines show, and orange lines as well, shows that their tumors have shrunk quite considerably, 90%, 80%, 70%. These are really excellent responses. And maybe even most encouraging, at least at last follow-up, none of these lines went above the 0 line, meaning none of these tumors grew while on therapy. So that's really quite huge for patients who often have many kidney tumors that have very significant effects on their life. Now, patients who have von Hippel-Lindau disease have other issues in addition to kidney tumors, and this medication seems to act on all of those things, which is quite exciting. Now, as I said, it's a pill, which is great, rather than an injection, but there are some side effects of anemia and hypoxia, which is low oxygen in the blood, and they can be quite significant when they happen. This, again, is another really exciting graph, and I think really speaks volumes. Now, on the x-axis here is years. So the red line that I've drawn is actually when patients started belzutifan. Everything to the left of that red line, which is in years, down to 10 years, and some even far beyond that, shows what happened to those patients with von Hippel-Lindau disease. Each line is a patient. And each black dot on the line is a surgery that that patient had. So as you can look at each of these individual patients, to the left of the red line, many, many surgeries were performed, some for kidney tumors, others for eye tumors, brain tumors, other things that can happen, but many, many surgeries that these patients have to undergo, which is quite significant. What's really exciting is that on the right of that line, there are very few of those dots. The red dots in this case would represent an operation after starting belzutifan. So it becomes quite obvious, even 2-3 years out, this is extremely exciting. Now, it is also possible that some patients may have delayed getting surgery because they want to see how well this medication works. I don't know. But after a couple of years, if we're starting to see similar things 3, 4, 5 years out, this is extremely, extremely exciting for us. Now, what this study showed is they looked at costs, and the way costs are represented here in this trial is the blue bar is the costs associated with surgery. So the first thing is, and then the green bar is the cost associated with complications related to the surgery. So before starting belzutifan, annually the costs were very high for surgery and very low afterwards, which you would expect based on the slide I showed you just before. But the other thing that this shows is if you look at the costs, and this is just financial costs, let alone the costs that patients are experiencing with suffering from complications or from surgeries, the majority of the costs, and I bet also the majority of the personal costs that patients bear, are after surgery dealing with complications or side effects from those treatments. But clearly beneficial to patients, also financially beneficial to our healthcare system. But we're not sure how much these, or I'm not sure how much these drugs costs. They are not, those costs are not in here. And of course, drug companies will not be giving this out for free. And I expect the costs of these medications to be quite high, but it seems like they might be well worth that money. Okay, this is the last study. This one is a bit of a confusing one, but it really did get a lot of social media attention. And that's part of the reason why I wanted to cover this study. So this is a Zircon study. When it comes to imaging kidney cancer, you know, Neil and I essentially offer the similar imaging to our patients now as we did 20 years ago. Now, the technology has improved slightly, but for the most part, no major shifts in how we can image patients with a kidney tumor. And we would like to be better at imaging kidney tumors because not all kidney tumors are kidney cancers. And we would love to know which are cancers, which are not, so we can treat the patients who need treatment and avoid treatments and treatment-related side effects in those that don't need it. So the study that was done here is called a PET-CT. Some of you may be familiar with what a PET-CT is. It's a specialized type of PET scan where a medication is given through IV and then certain cells light up on that CAT scan. The drug or the agent used in here is called girentuximab, which is a mouthful. So for those who are interested, if you're not interested, you can ignore this slide. Carbonic anhydrase is a protein that's expressed in clear cell kidney cancer, not all kidney cancers, but clear cell kidney cancer, which is the majority, about 70% of kidney cancers are clear cell. And this protein is almost only expressed on those kidney cancer cells. So they generally are not expressed by other cells in the body. They may be expressed by some, but that's another story. So this could potentially be a target for treatment or for imaging because you could get antibodies that would bind to that protein called CA9. And if there's medication attached to that antibody, it could potentially kill the cell that's expressing CA9. Or in this case, it might light up and be detected on a CAT scan, on the PET scan that we're talking about. Now, this protein has been known for many, many years. In fact, 20, 25 years. Different studies have been done looking at this protein, but this is one of the first real, I would say, good studies looking at PET scans. So the antibody itself is called girentuximab. It has very low side effects. There was a trial actually that many of us in Canada accrued to called the ARISER trial, looking to see if you gave this antibody to patients, would their tumors actually respond? The good news is there was essentially no side effects to the medication. The bad news is it also didn't work as far as an adjuvant therapy. So this is a cartoon. So this blue orb that looks like the planet Earth is representing a clear cell kidney cancer cell. The little purple things is this carbonic anhydrase 9 protein. And then these kind of upside down Ys are the antibodies that would bind to the cancer cell. And the blue dot that's attached to that is the girentuximab, and that's the thing that glows on the CAT scan. So what they did with the study is they took patients who had what's called a clinical T1A or clinical T1B tumor. So tumors that have not spread through the body, they are localized to the kidney, and they are 7 centimeters or less. So some of these are still fairly large tumors. They give the medication, and then 5 days later, the patients came back and received the PET scan. Then they had surgery, either their whole kidney removed or just the tumor from the kidney, called a partial nephrectomy. And what they wanted to do is they wanted to see how many of these cancer tumors lit up, how many of these cancer tumors did not light up, and that would tell us how useful this might be in imaging patients before their surgery. As I said, these were patients with kidney tumors who were planned to undergo treatment, but we weren't sure if they had cancer or not. The outcome is something called sensitivity and specificity, which is a little bit confusing, but I'll try and kind of break it down into understandable terms. I'm going to skip through this. This is really just to say that most of these patients had tumors that were about 4 centimeters, and that these were the histologies. So clear cell carcinoma, which is what we've talked about, is about 70%. And then there were a bunch of other kidney cancers that were in the trial, and also some patients who had benign tumors like oncocytoma and spindle cell tumors, etc. Okay, so the sensitivity and specificity was 85 and 87%. That I can tell you is pretty good. You know, anything around 90% is pretty good. Not perfect, but pretty good. The way to understand this is that for the sensitivity, 15% of clear cell cancers will be negative on a PET scan. So even though the tumor doesn't light up, there's still some tumors that will be there. And some tumors that did light up were not clear cell cancers, so about 13%. You can think of it in a different way. So the way that I would use this when I'm approaching a patient, if we had this study in every patient, which we don't, but when I see a patient in the clinic who has a 4 centimeter tumor in their kidney, I can say, look, your chance of cancer is about 80%. The chance of this being a clear cell cancer is about 67, 70%. If we had this medication, this PET scan, I could actually increase our probability of it being a clear cell cancer to 93% if the tumor glowed on the PET scan, or I could tell the patient the risk of it being a clear cell cancer is only 25% if it doesn't glow on the PET scan. So I think what you should take from this is that this is interesting. It certainly might work, but as you can tell, it's not perfect. And most diagnostic tests, in fact, almost all are not perfect. They can help you to understand your risk of a disease, but often they can't tell you 100%. Even a prostate biopsy, believe it or not, is not 100% because sometimes they're working with a very small amount of cells. And so what the biopsy shows may not actually be correct. And it's important to understand that. Now, I think that I could foresee a clinical trial. I would, certainly be very supportive. And I think many patients would be interested in, having potential access to this sort of imaging to see if it affects patients' choices on how they want to be treated. I think there are some, if you think about this a little more, patients who have cystic, so not completely solid tumors, are very difficult to know if they have cancer or not, and maybe this test could help. One major thing that Neil and I, manage a lot is what if somebody has a kidney tumor and they have a few little spots in their lungs or a little spot in their adrenal gland, and we're not sure if the cancer has spread or not. So we're not sure if they should be seeing me for surgery or seeing Neil for medications. If this test was useful, maybe this PET scan would be helpful in saying, look, these are not lighting up on the PET scan. Let's assume that this patient does not have spread of cancer, and let's offer them surgery. Or if they do light up, say, look, what this person really needs is medication, systemic treatments, and maybe we'll delay surgery if the person responds really well. And then there's all kinds of other interesting possibilities. As I mentioned, what if instead of a tracer that gets picked up by a PET scan, what if you use this antibody and put a radioactive agent on that, so that that radiation could potentially kill the cell that's being attached to by the antibody? That would be obviously extremely exciting for us as a new potential treatment for kidney cancer. And there are some studies being looked at for that, and maybe we'll have to come back in a year or two when we have the results for that. So thank you very much for your attention, and I hope some of that was understandable, and I'll hand it off to Neil.
Great talk, Rod. It's gonna be a tough act to follow. And thanks, Christine, for giving me the opportunity to speak tonight. I have to apologize. I think anytime we give a talk, I should have had a conflict of interest slide, but I'll just verbally tell you that the drugs I'm talking about, I have done some advisory work for Pfizer, Ipsen, and Merck. So open to that disclosure. So we'll just go ahead one slide. So I'm going to talk about more so the medication side of things. And so I'll talk a little bit about first-line treatment, some updates on some regimens that are already out there, and then some data on updates on second-line treatment of an existing drug that, being reported in post-immunotherapy. When it first came out, immunotherapy wasn't around. And then I always like a little fast five of some Canadian content at the end. So I'll be quick so we have some time for questions at the end. So as everybody knows, the field of renal cell carcinoma has dramatically changed over the last 20 years, going from sorafenib, and then one by one, a number of individual drugs came along, and then we got into combinations of drugs. And as Rod recently mentioned, we've now had some success in the adjuvant setting of using these drugs, not in the metastatic setting, but also in the adjuvant setting. Kidney Cancer Research Network of Canada, which Rod and I both belong to, publishes after our annual meetings, usually a consensus document of different drugs and where we recommend them. And you can see here that we have the untreated first-line patients. We stratify patients based on the IMDC risk factors, which is the International Metastatic Renal Cell Database Consortium, which is led by a Canadian, Dr. Danny Heng, and is fed through the Canadian Kidney Cancer Database feeds into this. And based on 2 clinical factors and some lab work, 6 factors, you can stratify a patient as to which treatment they should get. So you can see the preferred treatments are combinations of hybrid drugs, VEGF inhibitor, these TKIs Rod was talking about, plus an immunotherapy. And if you're in the group that's intermediate poor risk, you have the option of dual immunotherapy and dropping off the VEGF inhibitor. So I'll be talking about, in particular where the red arrows are, the nivolumab cabozantinib combination as the first study from ASCO-GU that will go over it. And that was the Checkmate 9ER. Now, this study was previously reported, and this is the 3-year follow-up to see if the results they initially reported a number of years ago have held up over time. So just to go over the study again, so this was previously untreated patients with the clear cell carcinoma, and they could be any of the IMDC risk groups, favorable, intermediate, or poor risk, and they got randomized to the combination of nivolumab and cabozantinib. So nivolumab, the immunotherapy, and cabozantinib, a VEGF inhibitor, against sunitinib, the original VEGF inhibitor that's been the comparison arm for years, and was really the first hit drug, one that's really dominated the market for years. And the primary endpoint was progression-free survival. Did it slow the cancer down? Secondary endpoint is, did it make people live longer? So on the left is the results from a number of years ago, which only had 18 months of follow-up, and then they've reported it now on the right side in the red box, the 32-month average follow-up. And you can see that the median progression-free survival, which is the first line, there was about an 8-month improvement in progression-free survival. On the right side, you can see it's exactly the same. 8-month progression-free survival is held up as the study has matured. Next line down, you see that the median overall survival, there was a hazard ratio that was reported in the first reporting that was 0.60, I mean, a 40% reduction in dying, but the people are doing so well, they didn't get to the medians yet. We now have what the medians are, and it's about a 3-month improvement in survival. And the hazard ratio, as we sometimes see as studies get more mature, dropped off a little bit, but it's still very respectable at a 30% reduction in death over time. And the response rates are again quite improved by doing the combination hybrid treatment. You go from a 28% response rate for sunitinib alone to a 56% response rate, meaning we shrink tumors down by more than 30% in 56% of patients. And that doesn't include the number of people that we hold disease steady. So this is quite significant and showing that it's a very robust first-line treatment. And I think what they've done is taken the survival curves that Rod talked to you about, showing how people have done in the study, and shows the first one top left is the favorable group, showing pretty much it's a toss-up between the two. The curves are overlapping. But as we get into the intermediate, which is top right, the curves start to separate. And then as we get to the bottom left, the poor risk group, the curves really separate. And the top line, the blue line being the combination, showing quite a significant improvement compared to if you just took a VEGF alone, the bottom black line. So overall, we're seeing quite significant activity in this regimen. Now, the interesting fact is you look and see what happens to people when they stop the treatment. Did they move on and get other things? So you could sometimes get radiation, you get surgery, or did they get another systemic therapy, another drug? And it shows that less than 50% of people actually move on to get something else. And that is something that we need to improve upon, that we need to have, active agents and get patients on them, despite following them on study, that less than 50% of patients moved on to another line of therapy. So just to summarize that, intermediate poor risk IMDC patients with that combination had an improved response rate, improved progression-free survival, improved overall survival, and a minority of the patients got subsequent therapy. So this is where the next study that I'm going to go over is in that intermediate and poor risk group. The patients, that maybe we should throw the kitchen sink at people, give them the double immunotherapy and add a VEGF on, and see if we can get better upfront response rates and longer survival. So the study that was presented at the meeting was the COSMIC 313 study. Now, this was previously presented in the fall in Paris at the ESMO conference, and that was the initial results. This is an updated results with another 5-6 months worth of time of the patients on study, but also looked at it in a slightly different way, where it was going to break it down by these IMDC groups. Okay, so here's the schema. Again, clear cell carcinoma, this time limited only to the immediate, intermediate, and poor, and randomized patients to the triplet of cabozantinib, nivolumab, and ipilimumab. And you can see that you get the triplet for 4 cycles, and then you drop down to a doublet because you only get ipilimumab for 4 doses, and then you get the single, versus a doublet of nivolumab and ipilimumab plus a placebo. So the doctors don't know which arm you're on. And then again, after 4 doses of ipilimumab, go down to a doublet of placebo and nivolumab. Okay, so this is a blinded study, and the primary endpoint was progression-free survival. Did it slow down the cancer? Now, the results presented in ESMO and the results presented today are just the progression-free survival. You still have a long way to go before you find out whether overall survival is affected by this drug. And here's the answer. It showed the progression-free survival was improved by being on the triplet. The orange line separated from the blue line, and the hazard ratio was clinically significant. And you can see in the red box, what was the progression-free survival benefit was about 4 months. They took that right-sided curve and then broke it down by the IMDC groups like they did in the other one. I showed you those 4 graphs, and it shows that The intermediate group had a significant improvement of 6 months in progression-free survival if you separated the groups. And unfortunately, the poor risk group did not see an improvement in progression-free survival. Response rates, interestingly, were not as brisk as we've seen with other combination therapies. And there's a lot of theories around that. So we're seeing response rates where the shrinkage of tumors in the range of 43% in the overall group, which is an improvement of 7% over the doublet group. And 45, and if you go to the intermediate risk group, that's 45% over 36%. So not a dramatic, but again, that disease control rate, which is that now includes stable disease, like stability, we're getting up in the 88% range. So that's quite impressive that we can slow cancers down, even if we don't shrink them, and up to 88% of people. Now, Rod talked about toxicity, and grade 3 and grade 4 toxicity is what we want to know about in studies. Grade 1 and grade 2 toxicities are mild side effects that we can usually manage, don't have to stop drug or maybe brief stopping of drug, but really don't have to do any medical interventions. But grade 3 and 4 is where we might have to stop drug and really intervene. And it shows that adding the triplet significantly increases toxicity. We're seeing that in the intermediate risk group going from 42% of people in the doublet arm to 74% of people having a grade 3 or 4 toxicity. In the poor risk group, again, from 38% to 67%. And at the bottom of the table, it's a very busy table, but they're just trying to break down, trying to figure out what the doctors thought, which drug was causing the toxicity. And the bottom line shows that over double the number of patients, steroids is a common drug we use in immunotherapy to tone down side effects. And that it almost went from 37% to 60% of patients needed high dose steroids to try to settle down their toxicities. And so that's worrisome to physicians. We don't like to have to do that. And so we need to sort out how best to manage this and who best to prescribe this combination to. So in summary, this dual IO cabozantinib triplet therapy has a higher response rate compared to doublet therapy in this population, showed an improved progression-free survival for the intermediate risk IMDC group, but at the cost of increased toxicity. So the discussants were saying that really this is not yet a standard of care. People would like to be able to either have a biomarker that could tell us who are the people most likely to benefit and make it worth the toxicity for a progression-free survival people may value. And over above that, we'd like to know the overall survival benefit. So right now, this is very fascinating information, but I would not say it's a standard of care in Canada, and even in the United States, the clinicians discussing it were cautious in recommending it as a standard of care. So if we move to second line therapy, there are a number of different options out there. You can see them in the red box. And it really depends what you got in the first line. If you just had a VEGF inhibitor, or you're one of the original approved prior to immunotherapy, you could go to an immunotherapy at that time with nivolumab. You could go to another VEGF inhibitor because one inhibitor may work even if the first one stopped working. If you had just immunotherapy before, you would probably go to a VEGF inhibitor next. And if you had a combination, well, then it's really again, VEGF inhibitors generally are the next line of therapy. So we're going to look at the drug cabozantinib, which was in both the previous studies, because that study, when it came out, there was very few patients who had ever had immunotherapy before. So how well does it work after immunotherapy? Because really most of the data is it was being used after a previous VEGF inhibitor. And this was the Cabos Point study by Laurence Albige from the Institut Gustave Roussy in Paris. And it was really two cohorts of patients, the people who got double immunotherapy is cohort A, and people who got immunotherapy plus a VEGF, and they followed them separately to see how well the cabozantinib was working. And to cut to the chase, it wasn't working too bad. You're seeing response rates of about 33% in cohort A, which is the people who had double immunotherapy, slightly lower in people who had previous 31% in cohort A and 25% in cohort B, the people who had previous VEGF inhibitors. So I think that these are respectable numbers and showing that after immunotherapy, and that it's a viable option and one of a number of VEGF inhibitors you could use. So quickly, I'll just jump out and throw out some, just so that Canadians are very active. We participate in the Cosmic 3813, but there's some, abstracts and posters that were out there that Canadians are involved in. So again, the IMDC database is run by Danny Heng out of Canada. And they had an interesting abstract looking at outcomes of patients with brain metastases in the immunotherapy era, and showing that immunotherapy with chemotherapy used in other cancers, we know that it has a difficult time getting to the brain. VEGF inhibitors, very unpredictable how well it got into the brain, but with immunotherapy, they were showing quite not uncommon responses and a very respectable hazard ratio for responses in the brain. So immunotherapy seems to have activity in the brain in patients, and this is out of a database, not a randomized study, but showing that if you have a patient with brain metastases, there is a chance that the immunotherapy could work in the brain. The next abstract, which actually should be abstract 636, if people are going to look it up, it was out of Princess Margaret, where they were looking at non-clear cell renal cell carcinoma, and it was a retrospective review of their cohort of patients. So not a lot of patients, because as Rod said, the majority are clear cell, but it did show that in their small cohort that took immunotherapy, that there was some evidence of responses to immunotherapy, because a lot of the research recently done in non-clear cell has, again, revolved around oral targeted therapies, and there's not a lot of data on immunotherapy. So it's nice to see that they've had some patients with response there, and we wait for randomized studies. So these studies are hard to do because the numbers of patients needed to do randomized studies, there aren't that many clear cell patients around to do those studies. So they're not the easiest studies to do. The next abstract is a real world experience of BC Cancer Agency. They have a great database at BC Cancer Agency, and they were looking at how well people who took the double immunotherapy did versus the hybrid therapy, and it showed very comparable outcomes. So choosing one over the other doesn't put anybody at a significant disadvantage in their real world experience, but you really tailor it to the person's situation and what you're looking for. Do you need a quick response from a VEGF inhibitor versus do they have a high type of tumor that's very responsive to immunotherapy, such as sarcomatoid? So you would, try to tailor which one you think was the best for the patient, but they showed very comparable outcomes between the two. So that was quite interesting. And then the next one, which is the IKCC global survey showing of 2,000 caregivers and patients. And they were presenting some very initial data from it. It's quite a huge database of information, but they just talked a little bit about number of people's approach for trials, the genetic testing, how many people had genetic testing. And I think the last issue, they also looked at patients' expression of what their well-being is, and was that being addressed in their care. So you can look that up at the ikcc.org website. They have the poster up there for review. And then last but not least, there's a radiation trial in progress that Canadians are leading. And so if you read in the textbooks, they'll say radiation doesn't work in kidney cancer. Well, that's a myth. Radiation works very well in kidney cancer, especially with the newer techniques. You can use it in the early stage to treat a primary kidney cancer if it's not amenable to surgery or radiofrequency ablation. We do radiation directly to the kidney. If someone has very few spots of kidney, sometimes kidney cancer in the metastatic setting, we may not give them systemic therapy. We may treat all the sites with radiation or combined radiation and surgery. Sometimes if you've treated the patient and they develop a few spots of recurrence, rather than giving them a systemic therapy with lots of side effects, again, treat the few number of spots, usually 1 to 2 spots in any one organ, maximum 2 organs. We may treat those with radiation. But this is, and then sometimes you might just treat the primary, even in metastatic disease, if it's causing problems. The study that I want to present is a Canadian study led by Dr. Ali Khan Lalani out of McMaster, and it's a multi-center study. Ottawa is participating in this, looking at immunotherapy, and you give us one cycle of the doublet, ipilimumab and nivolumab, and then you treat the kidney with what they call a stereotactic body radiotherapy, and that's high dose radiation, 5 fractions, so not a prolonged course. And the theory is that it might control the kidney cancer a little better and remove the bulk of disease. But there's also what they call an abscopal effect, that they've seen that if you treat the primary, sometimes the mets shrink. But also a third thing might be is it might release a lot of antigens, things that the immune system can see, because that's what we're trying to give the ipilimumab and nivolumab do, is to increase your immune system to go after the cancer. And maybe by releasing these antigens that the immune system can see, you might get a better response. So this study is ongoing. We're actively recruiting, and was highlighted at the meeting as one of the studies to watch. So I'd just like to thank Kidney Cancer Canada for all their support. This is a part of the Kidney Cancer Research Network. It's much bigger than this, but this is a small group that was, and you can see Rod in the front row there. And in particular, I want to point out on the end of the row there, Anil Kapoor, who unfortunately recently suddenly passed away. And he was really a leader in our research network, and we're really going to miss him.
Thank you so much, gentlemen. I think that we have some questions. Thank you, Dr. Bro, for answering the 2 questions in regard to the Zircon study. I just wanted to point out to the 2 people that did previously put the questions in the chat that Dr. Bro did answer your questions in writing. So I hope that you noticed that. And if not, you can check them out under answered. I do have some questions, if you don't mind. One thing is stable is a really good word, a very positive word in the kidney cancer community. So I'm glad that you were bringing that up. And the cytoshrink, I do have a patient ask a question in regard to radiation therapy. It's just a general question, is a common side effect in SBRT that there is swelling, either immediate or delayed? Do you know? I know I'm kind of, I know it should really be.
So we would expect, stereotactic body radiation is different than old-fashioned radiation, which was they just blocks and they treated and everything got kind of the same dose all around, whatever they were treating, and can be quite toxic. Now they're able, with their fancy new machines, conform the radiation to really drop the highest dose right in the spot they're aiming for, but still areas around the kidney will still get a small dose. And how radiation works is creates a big bruise, right? And so the tumor we expect actually will swell before it shrinks. The maximum shrinkage from the tumor isn't immediate the next day. It takes weeks to months to see the maximum shrinkage. The maximum shrinkage is generally at least 3 months down the line. So we don't do scans too early to sort out how well we're shrinking for the kidney, but you can see initially some growth before the shrinkage because all the cells are swelling from the damage, a bruise, and then they shrink down. Normal tissues will do the same things around that. And again, that should settle down over weeks to months.
Okay, thank you. That was really informative. That's going to be really helpful to a lot of our patients. Dr. Bro, your information on adjuvant therapy was really helpful. Thank you. I know it is a little bit controversial, this adjuvant therapy. And I just want to throw out there that Kidney Cancer Canada is working in collaboration with a panel of kidney cancer specialists to produce a decision aid on adjuvant therapy for patients and caregivers. It's a difficult situation, and an informed patient can make a better decision. So it is forthcoming. We are working on it. And I also want to reiterate, and maybe Dr. Bro, you can speak to this, it is a small population in kidney cancer that is eligible for the adjuvant therapy. Is that correct?
Well,
like a specific stage and grade, or?
Overall, yes, it's a fairly small number of patients, but because a lot of patients have, very small renal masses that we might observe. But most of the aggressive variety of kidney cancers, which is probably about 20% of non-metastatic, would be eligible. So it's not a small number that would have been eligible for these trials. The number that should receive it, we don't know, because we don't really know yet the true benefits and risks. The long-term outcomes are not available.
Okay, thank you. And I have one question. I know you were talking about the, the Zircon, the PET scan, and I'm going to put I'm going to ask for this answer in very simplistic terms, because we often get questions, should we be getting a PET scan? And I know PET scans aren't offered, you know, generously.
Yeah.
I think sure there's a lot of thought that goes into the decision to do a PET scan. Is it true, or maybe you could explain to us, a PET scan, we understand that it's a kind of a full body scan or an area body scan, and the cancer cells will light up on that scan. Is that true?
Yeah, so it's pretty confusing because not all PET scans are the same. The most common PET scan that is used is something called an FDG PET, which is a PET that looks at glucose uptake by cells, essentially sugar uptake.
Okay.
And we know that cancer cells often take up sugar. So many cancers will light up by taking up sugar when we do PET scans. So there are some cancers where we do pretty routinely do PET scans, but it's only if it's of benefit. And in kidney cancer, it has been studied that these traditional types of PET scans are not really all that helpful, because some cancers don't light up and other areas do light up that are not cancers. And the other difficult thing is that the kidney uses a lot of sugar. So when you do these FDG PET scans, the kidneys light up like light bulbs, not because they're full of cancer, but because they're a high metabolic organ. So the traditional PET scans, unfortunately, are really not that helpful for patients. So there's really a rare reason to ever get one. Okay. Now, this type of PET scan that I was talking about has a radio label. There are different types of PET scans that are kind of specific for specific cells that are targeting. And we're kind of hoping that this one might be beneficial. My feeling is we probably need something more, like maybe even another molecule in addition to the girentuximab to be really clinically useful. But, you know, as I mentioned in my talk, I can see some potential things. And somebody asked in the question, is it useful for metastatic patients? We don't know. We do know that that antigen that I was talking about, CA9, is not expressed as highly in cancer metastases as it is in tumors in the kidney. So I think we should be cautious. We need to study it, but we have our fingers crossed for sure.
Perfect. Thank you so much. I am going to do a question in the question and answer. Were there, and I'll let you decide who should be the best to answer, were there any decisions or discussions, on the efficacy of the newer CAR T trials? There doesn't seem to be very good or many options for patients who have already had IO-TKI in the first line. Maybe Neil, you'd like to answer?
Probably CAR T's in my my ballpark, and I have to admit I'm a bit CAR T naive. It's really limited right now for standard use in the hematologics, blood tumors. It's coming down the pipeline for solid tumors, but it's going to be probably years before it's seen. And I haven't seen a lot of data or any data personally in the renal cell population. Exciting stuff, though. I totally agree. It's a new way of thinking, but very labor intensive. Canada has a network that's really dedicated towards this. Ottawa has a manufacturing facility for CAR T cells. So we're very lucky to be part of that, and stay tuned. But yeah, unfortunately right now, a bit early in the solid tumor area to make any comments. So sorry, don't have much to share.
No, that's fair. That's fair. And this kind of actually leads into another question. We have a lot of patients and caregivers, especially lately, with the difficulty in getting some of the systemic therapies in Canada that are, prime therapies in the US. And I know it's a very complicated, probably, process, and maybe difficult to answer, in the Canadian landscape, but can you offer a simple answer, like why are these drugs offered, such as, I'll use Cabo-Nivo, so readily available in the States, and it's being so difficult to put through? I know that it's gone through approval, and now we're, I think, into the funding level maybe. And is it just government, or maybe you can just give a little bit of insight?
Yeah, a little complicated, Cabo Nivo. Some of it has to do is it's two different drug companies for the two drugs.
Yes, it
So
does.
that adds complication of who's going to take the lead on putting it through Health Canada approval, because while both drugs are available in Canada, to get it funded, it has to have Health Canada stamp that indication, and they have to apply for that indication. And nivolumab, they both have good markets where they exist now. So, but once that ball starts rolling, which, as you said, it is, that will finally. So typically drugs that are available in the US become available at some point in Canada for the same indications. We generally lag behind the US anywhere between 6 to 18 months. This one just lagged a bit longer just because of the two drug company issue. But we can get access to them. You mentioned belzutifan earlier. If there's a home run hit drug like belzutifan, if it wasn't approved by Health Canada, we could actually still get access to it through a special access program for, because it's a very unique population. If a patient really needed it, we would have been able to get it prior to it. Now, once it starts into the Health Canada and gets the approval, then it's, from the Canadian supplier, we have to get it. And there's, usually access programs to bridging that point between available in Canada and funded by your province. And the pharmaceutical companies are very helpful in that window, that gap window, but that gap window ends at some point, and then sometimes we have gaps again while we're waiting for put the pressure on the province. And so that process from Health Canada to drug approval hopefully is less than 2 years, but it is complicated. And yes, I feel the frustration of patients seeing things come out first in the US and then subsequently in Canada, but they eventually do make it here.
Thank you. Thank you for that. And it is very helpful for another explanation for our patients, because it is sometimes hard to comprehend, especially when you are in a situation where you're really hoping to be able to access that drug. And that is a constant question that we kind of face. So speaking of belzutifan, right now you mentioned it's for a specific type of kidney cancer, VHL patients. Do you foresee, and not in the near future, let's not, kind of get people excited, but do you foresee that could be a possible clear cell RCC treatment?
Yeah, I think we definitely can see it coming down the pipeline for clear cell. We in Ottawa are lucky enough to be participating in a phase 3 randomized trial of it in the second line in combination with other drugs to try to see if it can improve the efficacy. The way belzutifan works is, the VHL gene, as Rod was mentioning, is the key in the pathogenesis of many kidney cancers, even if you don't have it in the hereditary. And HIF alpha is one step above that, feeds into that. That gene is broken and HIF is just going through, and HIF alpha blocks that. And so blocking at multiple levels in the chain of events, we anticipate will help. And so maybe not in everybody, but in combination treatments, we're very optimistic. And so, yeah, it's just going to take studies. And these studies, when you're dealing with clear cell, are usually big studies. They take a while to happen, but they're going on as we talk right now. And I think that the rate of progress of these studies and the rapidity that they're reported is picking up pace with time. Like it used to be 10 to 20 years to get a drug to market. Now it's 3 to 5 years to get a drug to market. So I stay tuned. I think we're going to see some results fairly soon.
Right. Okay. Speaking of what might be coming, questions that I found the comment very interesting, that a lot of patients, 50% or less of patients, move on to further lines of treatment. And actually, I was in a learning session with a group, and they said the same thing, where at Kidney Cancer Canada, we see a totally different reality. Like so many of our patients are looking so far forward. And so that's my next question, and maybe both of you can chime in. What do you see as, line 4, line 5, line 6? We have patients on 7 and 8 that are desperate to know what is available to them, what is possible, and should they just be talking to their oncologist, or if they're not getting answers, I'm just throwing it out there for conversation. Who wants to take it?
So I mean, we're fortunate in Ottawa. Rod is part of the OHRI in the clinical trial system. Our cancer center has over 100 trials open at any one time. So when we start getting past standard of care, like you said, 6, 7, things that we start looking for trials for patients, and that's where we probably can make our biggest gains. We have a phase 1 trial group in Ottawa that is new drugs, either new combinations or new drugs never used in humans. CAR T cells, we're going to start doing CAR T cells studies soon. So I think that's when you start getting, and start thinking outside the box too. What kind of progression are they having? And that's where we might get Rod back involved, or one of our radiation oncologists. If it's what we call that oligo progression, where it's very few spots, think outside the box, maybe stay on the systemic therapy you're on and try to manage the areas of progression with a different modality other than systemic therapy. So that's, unique scenarios, but we always try to never give up on a drug for, throw the baby out with the bathwater,
Exactly.
If we're having a good response in the majority of disease. And sometimes slow progression is better than rapid progression, and we keep people on drugs, as long as possible, as long as it's not popping up new spots and they're feeling well, right? It's all about quality of life.
Quality
right?
of life. Yeah.
And if the drug person's tolerating it, we'll do that. So there's lots of different options, but yeah, it is we do have some success stories of people really. So while we say less than 50%, there are still some very good success stories.
Oh my gosh. Yeah, for sure. Dr. Bro, would you like to make any comment, or just echoing?
No, I think Neil said it very well there. I think that's where really research is key, and access to
key. Yeah, for sure. We did. Oh, let me just double check. Sorry, before we sign off. Let me just make sure it's not a personal question. Okay, I can maybe turn this into not personal. Do pharma companies do studies asking for a biopsy from an unsullied organ, for instance, the liver? Is this standard? I'm not.
Yeah, no, I mean, that is actually the future of clinical trials. A little bit of its capacity of the current system to do that, but more so in lung cancer, it's fairly common. The studies are now asking to rebiopsy sites of progression to see what the genetic change is at the current time to help tailor therapy. Kidney cancer, not so much, but I don't see it too far in the future that we'll probably be doing that. Problem is the capacity of our system to do those biopsies and the molecular testing that's needed to do that. So yes, that is coming down the pipeline. More interestingly is liquid biopsies, looking for cancer cells floating around in the blood, and that's much easier to do. And we do see that a lot in the studies now. I'd have to check our belzutifan study where they're doing that, where they try to find the active cells, probably the ones that are causing the issue, or more likely to be floating around in the blood, and give you an accurate picture rather than the original biopsy you had when your kidney cancer was diagnosed. So that's probably the easier and hottest topic these days is liquid biopsies.
Okay, now you opened that can of worms, so I'm going to ask you to speak on it for just a second, because that is a lot of questions, and I am not informed on that. Are liquid biopsies available in Canada, or is it not what we interpret? Like, is it on a certain level, or?
So it's not a standard of care. It's a research thing. Most of the time that we're doing it in our cancer clinic. Now there is a liquid biopsy available from Foundation One. That I think they call Foundation Liquid. I'd have to see. They do offer a liquid biopsy. Now the success rate of liquid biopsy isn't as great as a tissue biopsy, so you have to take it with a grain of salt. As if an answer is negative, it just might not be. There's enough cells floating around, but occasionally we do get some interesting results when we do that. In kidney cancer, the success rate of finding a mutation may not be as high as we see in lung cancer, but anyways, people can. I do know, and there's there's other companies coming into the market for that as well. I think Connexia and a few others. So I'm sure if people just Google liquid biopsy cancer in Canada, there's a few companies now getting into that.
Okay. So stay tuned. Stay tuned.
Yes, exactly. Yeah, well, that's there. We just don't know how to interpret the results sometimes. Rod's better on that in the translational, how much, is people, we find lots of mutations, we just don't know what they mean sometimes, right? So, just because you find a certain mutation doesn't mean we have is it actionable? Do we have a drug for it? Do we have something to treat it with? And so, but it's that'll come with time.
Okay, did you want to add anything to that, Dr. Bro?
It can be a little bit confusing. I actually don't love the term liquid biopsy because it is a little bit confusing from an actual tissue biopsy of a tumor, where what we refer to as liquid biopsy could be looking at DNA or RNA or circulating tumor cells from the blood. It's like a blood test where it's filtered. Whereas some patients may actually need, like if Neil and I have a patient who presents with, unfortunately, metastatic kidney cancer, we need to know what type of kidney cancer that is, what variety, to know the best systemic therapies for Neil to give, or if we should do surgery or not. So that could never really be, we don't think, derived from the liquid biopsies. A lot of the liquid biopsies right now are to say, look, there's a lot of cells, there's a lot of DNA around in the blood. That might be a predictor of better response to treatment or potentially not as good response to treatment. So I would think when you think of biopsy, that's very different than the liquid biopsy thing. But but it is very exciting. It's extremely exciting. And
yeah, very good points, Rod. They're not diagnostic to diagnose for kidney cancer for sure. We're just looking for treatment options. And Rod brought a good point that there's lots of research on just volumes of cancer cells in the blood. That's another area of research too, like every drop in the volume. So that's a great point, Rod.
Okay, thank you so much. I've kept you long enough. We're over time, so I can't say thank you enough. This has been so informative. I'll just say to our audience, thank you. We've had great attendance all the way through. People have been interested in what you've had to say. And if you didn't happen to get your question answered this evening, please feel free to email us at info@kidneycancercanada.ca, and we'll do our best to get the answer for you. And once again, Dr. Bro and Dr. Riom, thank you so much, both from Ottawa Hospital Cancer Center, and we thank you. It's been a pleasure. Thank you.
Well, thank you. Thanks, Rod.
Yeah, we're Neil.
Thank you, everyone, and take care. Have a good evening. Bye for now.